Muy buenos días a todos y todas. Good morning, ladies and gentlemen, and welcome to today's webinar. Bom dia, senhoras e senhores, e bem-vindos ao webinar de hoje. E bonjour, mesdames et messieurs, et bienvenue à notre webinar aujourd'hui. First of all, this event will have simultaneous translation in Spanish and English. You can select your preferred language by clicking on the globe icon at the bottom of your screens. Now, once again, on behalf of the Pan American Health Organization, we welcome you to the webinar Improving Mental Health Through Social Determinants. My name is Katerina Molek, and I am an international consultant for mental health at the Pan American Health Organization. And today, I have the pleasure of accompanying you as the moderator of this event. The recording of this webinar will be available on the organization's YouTube channel and also on the events webpage. We are posting the YouTube link and event page link in the chat. Next, we will present today's agenda. So please, let's share the agenda for today, and we invite you to join us for the next 1 hour and a half. Just 1 second, please. We will have at the beginning of this agenda the welcoming words by Carmen Viciana, who is regional advisor from the Pan American Health Organization. We are having today a small change. Then we will have the presentation of the social determination of mental health, concepts and reflections by Fabrizio Mendes. Following the presentation of Intervening Social Determinants of Mental Health in Latin America by Franco Mascaliano. And at the end, presentation of experiences of social labor inclusion of groups in vulnerable situations, learning from situated practices by Marina Soledad Burrone, Marcela Inés Freites Frey, Marina Feldman y Raúl Tito Quintupra. After each presentation, there will be 5 to 10 minutes allocated for questions. Although brief, the time will allow us to delve deeper into each presentation. Important, we will use the chat for comments and the questions and answer function for questions and concerns. Please submit your questions through the Q&A function to make it easier for us to access them and avoid confusion with the comments. Next, then I will hand over to Carmen Martinez, who is Regional Advisor in Mental Health and Substance Use at PAHO, who will deliver the welcoming words for this webinar. Carmen, the floor is yours.
Muchas gracias. Thank you very much. On behalf of Renato Oliveira, our Unit Chief for Mental Health and Substance Use in the Pan American Health Organization, I would like to extend a warm welcome as you join us for this webinar titled Enhancing Mental Health via Social Determinants. As you know, this event is the second one of a series of events of webinars this year in 2024, focusing on foundations for transforming mental health in the Americas. At PAHO, our unwavering commitment lies in guiding and supporting the diverse populations of the Americas region in addressing their mental health needs. We extend really a warm invitation to each of you to actively participate and contribute with these collective efforts to foster positive change within the mental health systems and services, contributing to enhancing overall well-being across the region. Throughout this webinar series, we will offer essential insights for successful implementation. We are going to copy here in the chat box the link for the series of webinars, so you can be informed in regular basis. And today's discussion will center around the social determinants of mental health, which encompasses factors such economic, political, and environmental influences that can impact mental health directly or indirectly. Understanding these determinants is crucial, necessitating multi-sectoral collaboration rooted in human rights principles. We emphasize the integration of mental health into relevant policies and sectors, including social protection, education, housing, employment, security, and justice, among others. Our aim today is to provide this comprehensive understanding of the social determinants of mental health, supported by global and regional scientific evidence examples to prevent mental health problems, promote well-being, and empower individuals on the recovery journey. We really want to express our gratitude to our esteemed team of experts for joining us today and generously sharing their insights. Additionally, we appreciate the continued support from our offices in the countries in the Americas region and the continuous backing from ministries of health and other colleagues from other organizations. And a really big thank to all of you for your invaluable participation and commitment, essential to the success of this event. Our hope is that you live with renewed inspiration as we are also building up invaluable insights, ready to drive the transformation of mental health in the Americas. Thank you for your significant contributions. Muchísimas gracias a todos y todas.
Thank you, Carmen, as well to you for these welcome words. And now I will switch to Spanish, as we are having today with us Fabricio Méndez. Fabricio Méndez es licenciado.
Fabricio Méndez is a master in sociology from the University of the Republic of Uruguay with a doctorate in biomedicine from the university in Spain. He has been a health analyst in Uruguay, consultant of care in Uruguay. Furthermore, he is a guest researcher in inequalities in the Fabra University. Beginning in 2002, he has been an international consultant in the health promotion and social determinant unit at PAHO, and that is why he today will be sharing with us his knowledge and expertise as to the social determinants of mental health through the presentation of concepts. So, Fabricio, please go ahead. Thank you very much. Hopefully you can see my screen. Well, thank you very much. Thank you for the invitation to this very important webinar and also a very interesting one. What I'd like to do is share with you some concepts and thoughts about social determination of health. This is a preparation jointly prepared with my colleagues from the Social Promotion and Determinant Unit and Dr. Solar. I will be giving the presentation, but this is collective work. Let me start by pointing out or going briefly over some of the core concepts having to do with social determination of health. First of all, I'd like to talk about what we mean by social determinants or social determination. We can find it in different expressions in literature and different documents and papers, both globally and in the Americas. Social determinants, as you well know, refer to the condition in which people are born, work, grow, live, and age, together with a broader set of forces and systems that shape the conditions of our daily lives. These forces and systems include issues such as policies, economic systems, development agendas, social standards, social policies, and political systems. This entire complex system is articulated in such a way that it impacts the daily life of each and every one of us, both individually and collectively. And this is what we see in the conceptual framework of social determinants of health of WHO, which you're all familiar with. This shows that there are a set of proximal factors that have to do with material circumstances, individual behaviors, and biological factors, as well as psychosocial aspects that have an impact on health and on well-being. But at the same time, these factors are the result, or they are determined by yet others that have to do with the socioeconomic status of people. And this in turn is determined by factors that are even more structural or distant that have to do with the socioeconomic and political context that I mentioned just a moment ago when I started with my presentation. Social determinants of health are not only exposure factors, they're not only social factors that endanger the health of people, but they are biologically incorporated in the human body. And this is what we find in the concept of embodiment that Nancy Prigger spoke about several years ago. This talks about the relationship between what is biological and what is social in a concept that tries to show us how the condition in which we live are biologically incorporated by the human body. There are a number of examples. There has been a lot of research, and I'm giving you a very simple example here of a study that is some years old already, but it shows how the socioeconomic level is associated with alterations in DNA and the shortening of the telomeres. And this results in some genetic modifications associated with the low socioeconomic level. So this is a key example, and there are many more, how the conditions in which we live are incorporated biologically by our bodies. There are three critical nodes between the relationship of social determinants and mental health, and this is what we wanted to highlight in today's presentation. The first is how the conditions of life affect mental health. The second is how we generate social and health inequities between people with and who live with mental disorders, and between these individuals and those who do not have or do not live with mental disorders. And the third critical node is how mental health disorders affect the social position and well-being of people associated with their social insertion, their occupational insertion, and discrimination and stigma. So with the first critical node, I'd like to give you two examples. One has to do with housing. In these two graphs, we can see, and this is a study on residential insecurity, and we can see how this insecurity measured in such as payment of paying rental, the risk of losing the housing, and this is based in a study in Catalonia. We can see that people who are in a situation of residential insecurity have the prevalence of having poor mental health measured on the Goldberg scale. 90% of people who find themselves in or at risk of residential insecurity declare or state that they have poor mental health. That's among women, and it is 84% in the case of men. Now, if we look at an example that has to do with employment, so we've left aside the housing and now we're looking at employment. In this study, we find that labor precariousness measured through insufficient income, not having labor rights, not being able to implement them, and other dimensions that have to do with precarious employment. But we see that there is a clear link between labor precariousness and poor mental health, measured in this case with a WHO-5 index. But we also see, when we ask how labor precariousness impacts mental health of individuals, We can include psychosocial risks as mediators, and we see that psychosocial risks do play a role in this relationship between precarious employment and mental health. What we're trying to point out with this is that there are some aspects associated to employment and housing, but there are yet others that can be added, and these work as mechanisms whereby social living conditions impact individuals' mental health. The second node that we're interested in has to do with how social and health inequities are generated in people with mental disorders. In literature, there are a number of examples to illustrate this. We wanted to present two hypotheses. One has to do with what we called the selection derives. This hypothesis that shows that mental diseases or their prodromes precede the perceived socioeconomic status of individuals. But there is another hypothesis, that of social causality, that emphasizes precisely that the socioeconomic status is a primary determinant of mental disorders and their prodromes. In other words, a mental disorder begins when the individual moves downward in the socioeconomic status levels. And the evidence supports the evidence of social causality and the selection derives. And this is highly linked with the type of disorder we're talking about. These are not mutually exclusive, excluding hypotheses, but they work over a broad spectrum of mental disorders and behavior. There are some incapacitating disorders, or they could be inherited or have clear biological origins, such as schizophrenia, can be attributed to the selection derives hypothesis. But then there are other types of disorders, such as the mood, that would, or anxiety, that are more linked to the social cause hypothesis. So these are two ways of thinking how the social conditions can generate inequity in mental health. The third critical node has to do with how mental disorders, no, I'm sorry, mental health disorders impact the social position and well-being of people. There's a study here that was carried out several years ago, actually, by Flaxo Twile. And what it shows is precisely that the precarious insertion in the occupational or labor market, whether it is precarious work or informal work, is also associated with deficit in social security, social protection, and all of this sets a labor path, a vital path, both of precariousness in the area of employment, but also lack of social protection that impacts the possibilities for social and labor insertion of people who live with mental disorders. To conclude, there are three messages we want to share with you because they are crucial to understand social determination of health. First is that disease is not distributed randomly, but they are deeply determined by the social, political, and economic structure in which we live. The second key message for us is that people living with mental disorders may achieve good levels of well-being, have a satisfactory life, one that has meaning, obviously within the limitations of the symptoms. It could be pain or anguishing or weakening of people with mental disorders, but the possibility of having a full life will also depend largely on the social living conditions of the individual. And this is associated with them having a decent housing, to have labor of high quality, that they receive timely medical care, therapeutic support, that they are included socially and receive social support, and to avoid, through active policy, any kind of discrimination and stigma for people suffering from mental disorders. So that is the outline of what we wanted to present to you, and we thank you very much for this opportunity.
Thank you so much, Fabricio, for this presentation. It has been very clear. You have presented the basic concepts related to the social and economic determinants of health, and also presenting analysis of things such as employment and housing. This presentation invites us to reflect on how the social economic determinants of health can determine or impact mental health of persons. Well, I was trying to see if we have any questions. We have two questions. The first one is from Miguel Moreno. Let's see. The question is, how is the mental health defined in the instruments that you have presented? So in other words, how to understand mental health from the viewpoint of social determinants of health, how we understand mental health from the social determinants of health point of view. And the other one is, how can we contribute as mental health professionals? Well, there are two very big questions. Yes, we could devote a whole webinar to each one of them. Well, the first one, I believe that what we tried to highlight in our presentation is that whenever we talk about social determinants of mental health, we're not only talking about of how certain conditions may contribute, or on the contrary, may hinder the social inclusion and labor inclusion of people living with mental conditions, or some other aspects of housing, their housing conditions, which have a direct impact on whether a person may develop or not a mental disorder. That's what we wanted to highlight with those examples we presented on housing and employment, and the negative impacts, such as whether a person has to live with uncertainty, whether they're going to have roof over their head, which will have a direct impact, and the development of mental health problems. And on the other hand, and this is another second important message, there is an issue of the characteristics of our surrounding and the possibility that we have because of our social economic conditions will also determine not only or will contribute to the fact that we develop mental disorder, but may impact the fact of whether we can have a full life or not. So that will be greatly impacted by our family atmosphere and surrounding the social environment, the community that we live in, social economic conditions, our income, and also possibilities of accessing education and healthcare and public health and so forth. And so those policies are determined by a greater context, which has to do with the development of public policy and also of social protection devices. So we have to think about thinking about mental health in these terms. It means that we have to take into account all these other aspects whenever we're conducting an analysis, rather than just one aspect that impacts on mental health. That's in regard to the first question. Regarding the second question, I'll be more brief, because in reality, I don't work directly with populations receiving healthcare services. So that's why in this area, organizations such as PAHO have very important role playing in this area, which provides tools to the primary healthcare workers by providing them the necessary information as to the conditions that those patients are living in. For instance, by using different tools about the different clinical settings, factors, and other conditions, social. So that will be timely information that will be provided to those healthcare providers. So that was an interesting question, but it really hasn't been worked on or developed in literature, but whatever we have available show very interesting results. Thank you so much, Fabricio, for summarizing something which is so complex and only a few words. Here we have several questions, and so we only have a few minutes for that. There was another interesting question from another aspect, which says from the private sector, how can we promote mental health? And also the promoting social economic conditions that has to do with the approach, how mental health is approached from a multi-sectorial viewpoint. Well, yes, there is a device or tool which is very interesting. And I'm sure that most of you will know about social Copenhagen questionnaire. This is a tool that has been designed for research, but also for surveying and assessing risks and labor risks working in certain companies. So it allows companies to develop certain tools in order to deal with those risks. And this is a tool that, based on the different models of social economic risk that have been developed, according to all those models, it has a multidimensional approach of social economic determinants, which makes it possible for companies to take concrete measures. For instance, we had an experience yesterday with Spain of the implementation of such a tool. So it allows companies to develop mechanisms in order to decrease the demand for workload and to lower or decrease the schedules of workers in order for develop the tasks, and also to activate some mechanisms to diminish stress, to improve the imbalance that can take place between family and work life, especially for women, which is a very high psychosocial condition impacting women. So these are very specific measures that can be developed on the basis of those instruments, which are very well documented and have shared very good, interesting outcomes. Yes, thank you very much, Fabricio. So now we would let you go. Thank you once again for having shared your knowledge and experience with us. And well, and now we continue with our next presentation. And here I would like to add something to the last thing that Fabricio said, that there is also something very interesting about mental health in the work. And there is a guideline that has been published by the World Health Organization together with the ILO, and you can find it on the web. And that includes also social economic aspects of mental health in the workplace. So now we will go back to English.
Head over to New York, where we will hear the presentation from Franco Mascayano. Franco Mascayano is a research scientist and director of employment research at the New York State Psychiatric Institute, Columbia Psychiatry. So Franco, I don't see you, I think, yes, I give you the floor, please.
Oh,
And
sure.
welcome.
Well, thank you, Katerina. Hi, everyone. Thank you for having me today. I was asked to present in English, so here we go. I'm originally from Chile, but I'm based in New York, and usually involved in research regarding social determinants and mental health in Latin America, but also in the US. Let me try to share my screen. Hopefully you can see the slides. So this is the name we came up with for this presentation, Intervening Social Determinants of Mental Health in Latin America. Here's an outline. I usually start with a brief outline for my presentations. I'm gonna present some rationale for social determinants of health and mental health. I mean, why social determinants are important in our field. I'm gonna also show you two conceptual frameworks that were developed by people in psychiatry or mental health services that I find informative and could be used for different purposes. And I'm gonna be talking about two examples of models or approaches, also called interventions, addressing the same social determinants that Fabricio discussed. First is housing. I'll be presenting the Housing First initiative focused on two locales in Brazil and in Chile. And individual placement and support intervention, that's a well-known intervention for helping people get jobs that we are trying to introduce in Mexico, specifically in Guadalajara. And I'm going to end this presentation discussing some main challenges and future steps for both doing research and also addressing social determinants in mental health. So in terms of the rationale, why to address social determinants of mental health, there are several reasons. I'm going to just try to highlight the main ones, in my opinion. First, social determinants account for a large proportion of inequities in mental health outcomes. And I'm not talking only about clinical stuff like symptoms or functioning, also access to mental health care, quality of care, continuity of care from primary care to, specialized services and so on. It's probably the set of determinants that explain more about what happens to people who are presenting mental health condition. Treatments understood as clinical treatments like like medication or psychosocial work usually, remain very limited in terms of their impact. Specifically, medications have reported some moderate effects on outcomes at best. So we definitely need to do more if we want to help people with different mental health conditions. In several of these conditions, several of these factors could be intervened by using different public health and policy strategies. And the two examples I'm presenting today are good examples of that. There are substantial benefits that we know that's been reported in several previous studies regarding, for example, receiving supported employment or receiving a secure, safe, house, as Housing First, does. So we know that people could get, benefit from, being exposed to these interventions, and also people will live experience, understood as people with mental health conditions have been advocating for a stronger focus on social determinants rather than, only discussing, I would say traditional treatment in psychiatry. Regarding the two frameworks I said I would present, this is one of them. It's quite similar to one of the frameworks that Fabricio presented. What I like about this model is that you have the set of well-known determinants going from discrimination, poverty, to air pollution and neighborhood safety and so on. But they are presented connected to other very important contextual factors, such as public policies, social norms, and how this could, working in tandem, affect several, health outcomes, including mental health outcomes per se, but also other health outcomes, like comorbidities, mortality, and so on. I added the link to the full paper, so you can have it. It was developed by Michael Compton and his team in New York. And this other framework / model was recently published. It was developed by James Kirkbride and his team in England. And what I like about this model is that the several social determinants are presented by developmental or development, phase, if you will. So you have, determinants that are closer to the individual in the household, like maternal stress, poor nutrition, and so on. And you have others that are more distal to the individual, like migration, social fragmentation, and so on. So you can see that there are several determinants that have already been identified, but the strategies should be multi-level because, there are several, and some of them are closer to the individual than others. I really suggest to check this paper because they also include several evidence-based practices that have some evidence for addressing some of these determinants. In terms of the examples, let's start with housing first. Housing first is a well-known approach for helping people to get safe homes, in other words. It's focused on locating people in permanent housing, and it goes, the other way around compared to traditional housing systems. So this is the traditional housing, process, right? So people are experiencing homelessness, and then they are located in shelter, placement, and then transitional housing and so on. But people have to comply with, treatment adherence, psychiatry stability, and, abstinence of, substances, right? They have to be sober in general. Housing first goes the other way around and locate people first, and it's very based on, people's choice of services, separate housing services from other services like clinical or, social services. So they are both conceptually and physically separated. They have a recovery-oriented, approach. So that means that this is about, helping people have quote unquote normal lives rather than reducing symptoms or, improving functioning. And the services provided have to match what people want. It's all the services, are structured around people's, choices and needs and whatever they want to do with their lives. That's like the general standard model. There are several small pilot projects of housing first in the region. I'm focusing on two that I think are more substantial, and one of them actually, the Chile experience has been, going on for some time. But the Brazilian experience is something recent. It was, I think, launched last year. There was this big international housing seminar. Many people, including the creators of the model, came to Brasilia, and the event brought together stakeholders of different kind, people with lived experience, providers, researchers, and it was organized by different ministries, which is quite unusual in mental health. It was organized by the Ministry of Human Rights, I think social justice or justice, health, and others. It was a wonderful experience. And this pilot project entails to have 10 projects in different, regions in the country, and implement around 50 units or places where people can, live, in all these places. So it's a massive initiative. It's happening now. And I can put you in contact with the people in charge, including my colleague, Ana Florence, who are, designing and implementing the initiative. The other experience is the Chilean experience, as I said before, and Chile is called Programa Vivienda Primero. And it's been active, I think, from 2018. And they adapted the principles and the strategies involved in the model, included in the model. And they have around, I think, 800 people, many of them with mental conditions, already located in individual permanent, housing, which is, I think, amazing. And the other intervention or / program that I wanted to present is IPS, Individual Placement and Support. IPS is a well-known intervention for support and employment and education. It's also recovery-oriented, and it also goes in a different direction compared to traditional, interventions. Instead of preparing people to get jobs, they try to, locate potential job opportunities, and they just put the people to work. They collaborate very closely with potential employers, and people are placed, and then they provide, different kinds of services to support them when they are already working, right? And it's a structure around these 8 principles. Is open to anyone who wants to work. It doesn't matter what kind of like mental health condition the person has. It's focused on competitive employment. These are not workshops. These are not people working for no money. These are regular jobs that anyone can apply for. It's based on rapid job search. It's also focused on people's, preferences and choices and so on. And it's been very successful. In my, opinions, one of the most successful recovery-oriented interventions reported, at least in Europe, North America, and other high-income countries. And we are doing a pilot project of IPS in Mexico, specifically in Guadalajara. People with psychosis are receiving IPS, and we are comparing that to usual care in terms of employment, supported employment. And we're collaborating very closely with the Servicio Nacional de Empleo, who provide services, employment services for anyone who want to work with or without a condition in Guadalajara and other places in Mexico. Here's more information about the project. Happy to discuss the implications of doing something like that, because one of the main implications is, the potential adaptations that we are discussing to do to the IPS model to make it fit in a different context compared to previous, research. You can understand that Guadalajara compared to Vermont, it's quite different. So we are going through a process of making adjustments to the model to increase contextual fit, if you will. And I'm going to end with this slide about challenges and next steps. And I'm going to be talking about challenges that apply to social determinants in mental health in general, and things that apply to specifically to Latin America and other regions in the Global South. First of all, I think the question about adaptations versus local models that have been developed by people in the region, I think it's a fair question. And that's why I'm very interested in hearing more about the experience in Argentina on cooperativas, right? Because me and colleagues have been trying to adapt models from developed elsewhere, especially in high-income countries, and make it work in Latin America. But that has to be done very carefully in our experience, because we don't want to promote, colonial practices. We want to do it very closely with the community, and so intervention makes sense to them. But it's hard. So I'd love to discuss that further with the audience, maybe some other time. Some of these interventions, are often quite distal to the mental health outcomes that they want to influence. And that could make providers, especially people in mental health services, feel that they don't have like a role in this, And in my experience, many of them have not had proper training in social determinants, so probably they feel they don't have the tools or the knowledge to do something about it, right? Some of these interventions, for social determinants require major social, economic, and sometimes political changes, so they could be difficult to design and implement. And that also requires interdisciplinary, approaches and collaborations that could be quite difficult in mental health, where for many people it's still like a very psychiatric kind of like field rather than, like a public health, field. And the last point I wanted to say is that the mechanisms through which this, interventions work, I think we still know little about it. There are many things that could be done from a research point of view in terms of how employment or education or housing could, improve the mental health of the people we serve. So that's it. Thank you.
Yes, thank you also to you, Franco, for your insightful presentation. with expanded also our understanding of the social determinants of health in mental health, and in sharing these evidence-based models to have a more practical view about how to approach determinants of health. We have here some questions and comments. I will switch now back to Spanish because they are in Spanish written. Hay un comentario interesante.
There is an interesting comment from a colleague in Mexico who says that the family and community environments that are not very favorable, where it still is a vicious circle, unemployment, underemployment with low levels of education and poverty, it's very difficult to implement measures to promote mental health. So people have abandoned everything as a consequence. So starting with the primary medical care, for this person, it's very difficult to deal with these situations as part of a medical team for mental health. So what can be done to promote and take care of mental health given this kind of situation at the primary healthcare level? Is this a question to anyone or for me? No, it's for you. This is a comment that I shared, and I also turned it into a bit of a question for you. Well, I can provide an answer to that, at least a start. As Fabrizio said, these are major questions, and there isn't a single answer to them. At the end of my presentation, I did touch upon this. As health professionals, and in particular mental health, our training with regards to social determinants is minimal. I do not recall ever anyone telling me that I ought to know more about housing or employment or education. And there was none of that during my training either. I learned through practice because of community mental health that when you see such a major focus, you get a little bit closer, but you're now looking at the individual. Something that is basic is to start talking about this, and to provide some kind of formal introduction to this field. I do believe that training, hopefully it will be constructive, will allow people to learn themselves and look at the learning model based on themselves. That could be a good suggestion. But there's another point. I do believe that there are strategies, such as the ones that I presented a moment ago, that are evidence-based. And then there are other strategies for which perhaps there is no formal evidence in the region that perhaps could be used and could be disseminated if people know about them, if they're replicated. I don't know. We can start talking about the fact that some things can be done. But if primary health care, and especially at the level of specialization, this is not discussed, then I don't know how it can happen. People just have to meet a required number of clinical hours, prescription of medicines, etc. If that doesn't change, then I don't know when we're going to be able to change the approach. But there are people here who know more about primary healthcare than myself, so I'd like to hear from them. Thank you very much, Franco. It's not an easy question, no doubt about it. Difficult to answer also, but as you said at the end of your presentation, that although it is crucial to look at the determinants at the individual level, it's better to do it through public policies and enhance them and to have programs. And here again, I'm looking at the intersectoral approach and comprehensive work between different services and different sectors. We have one additional question. This will be the last one. And it says, in the social determinant models, the factors affecting vulnerabilities of individuals are emphasized. So, should one not include the growing social inequalities that our societies are facing as a process of central determinant of the collective issues having to do with mental health? Well, yes, of course. The simplest answer is to say yes. I believe that the field of health social determinants has developed importantly in Latin America. There are several individuals, including the doctor who was unable to come today, Solar. I read some of her papers last night. They were very interesting. The cash transfer program in Brazil, for instance, it was called Bolsa something. Then there's the Chile Grows With You, Chile Crece Contigo in Chile. So there are many social health determinants in the region, but their impact on mental health is not included in all of this, or very seldom. My opinion is that mental health, and I would not like psychiatrists participating today get offended, but it's been taken over by psychiatry. Mental health is still being thought of as psychiatry or its equivalent. If this notion is used as a standard for what you see in the region, then it's difficult to include social determinants. There's no room for it. I think it's easier to have this conversation if you're looking at mental health through the lens of public health. And I think it's a good sign that psychiatry is focusing on this, but I think it's also the role of people in public health. They need to think about mental health more and to consider all this world of evidence-based interventions and everything that's been discussed today. It's a little bit tied up tightly looking into through the lens of psychiatry instead of the social lens. I don't know if that answers the question. It's just thinking aloud, really. I do think you answered the question, and you did so very clearly. And there are other comments here from participants, and most of them welcome what you said, and they agree with you that psychiatry and mental health are truly needed to be split, need to be separated or opened up. Okay, it is now time to move on to our next presentation. And Franco, let me thank you sincerely for participating with us today. And we now move from the Northern Hemisphere, New York, to the southern one, Argentina, Chile, and Australia also, because we also have a participant giving a presentation from Australia. They will be sharing with us experiences on the ground about experience of social participation and inclusion of groups in a situation of vulnerability. So we're going to hear examples of inclusion and collective responses in addressing social determinants for public health. And in this case, particularly, it is the socio-occupational inclusion through collectives. Or each will talk about their personal perspectives and experiences and share with us on that basis. So let me briefly introduce them. We have Maria Soledad Burrone. She's a professor at the Health Science Institute of the O'Higgins University in Chile. Soledad is a doctor, has a master's in public health, and her different projects include 4 projects having to do with implementing collectives for people in a situation of vulnerability. We also have with us Marcela Inés Freites Frey, who a professor at the Social and Community Health School and Dean of the University of Chubut in Argentina. We will hear also from Marina Feldman, who has occupational therapy and coordinator of the social company El Caldero in Chubut, and Raúl, or known as Tito Quintuprao, from the El Caldero social enterprise. So welcome to all of you, and I offer the floor to you. Please go ahead. Well, good morning or good afternoon, as it may be appropriate. Let me now share screen with you. Please let me know if it's correctly in presentation mode. I just have 5 minutes, so let me set a timer to make sure that I don't go beyond that. I wanted to tell you a little bit about a practical experience. It's what we're doing in Chile. We specifically began in the region of O'Higgins and then scaled up this practice to include other municipalities, and I'm now going to tell you about it. But we understand cooperatives as a model for social inclusion and recovery. So let me tell you about this in 5 minutes. As we have heard today, we started with people with mental health, but we also worked at people of the autism spectrum because these groups made us think about what could be done. And we think that together with the need of including women in a situation of vulnerability and aging of the population, universities could do something interesting working with the community and with government agencies through cooperatives. We believe that social cooperatives, and looking at the Italian model in particular, and that is precisely why we are all here, because Marcela Freites and Magdalena from the different universities of Chubut and 3 de Febrero allowed us to adapt this model to Chile. So here we need to show also how important collaborations are to generate practices, in this case, inclusive practices. So our understanding is that cooperatives can generate social inclusion, promoting independence and autonomy, and it could be a good perspective. And this is important. It's a way of generating employment and understanding employment as a right, but it's not for everyone. This is simple one additional proposal for labor inclusion. That is what gave rise to Potencia T, that generated 3 cooperatives originally in the O'Higgins district of Chile, that included people with mental health problems, elderly people, and women in a situation of vulnerability. And this resulted with a specific group to generate a service that had to do with the tourist sector in this case, working through community participation, looking at recovery through work in network and teamwork. These were the 4 fundamental pillars. And each of the 3 cooperatives that we set up had these kinds of individuals within their cooperatives. So we worked with them. How did we begin? We identified first people who wanted to be part of these cooperatives, creating the network, strengthening social capital, strengthening the social and labor skills. And the product or the service that was developed by each of these cooperatives were not defined by the team, but they were defined actually by the people involved in the cooperative. And that's what's important, because we really focus on participation and obviously providing support and training, practice in order to ensure the sustainability of these cooperatives. And we incorporated technology and virtuality. So it was very interesting. And we think it also gives sustainability ultimately to the products that are generated. This gave rise, this is the corner of the poets, one of the cooperatives. This is another one of the cooperatives, fruits of that provide jams and things. You can see some images of their products. The Seeds with History Cooperative, this is one of the groups that are in the O'Higgins district by the beach. They have a food truck there. In addition to selling regional products, they also sell other products that they manufacture. You have some images here of what they manufacture. Let me spend a minute on this because we heard from Franco. We also tried to generate evidence about the practice, and that's we have quantitative and qualitative measurements in order to perform an evaluation and assessment as to the validity of these practices. On the basis of this, we were able to develop a new project in a region where we were able to scale it up into a proposal that now encompasses 20 municipalities. We became an incubator of inclusive or cooperative, where we are creating and strengthening a network of cooperatives for social occupational inclusion, not only for these people, but also people in the situation of a disability. There is a policy of the National Secretariat for Disability that favors the creation of cooperatives and the incorporation of people into them, and that allowed us to have this scale up. And that is also another important factor to show a good practice can be scaled up and can become a public policy or strengthen one. These are different images because today we have more than 20 groups or cooperatives or pre-cooperatives in some 20 municipalities. Which are the key aspects? And I'm exceeding my time, but there is methodological approach. There needs to be a competitive, decent, sustainable employment. So it's important, in our opinion, that these cooperatives should not become a health space or device, nor one for education. Sometimes special schools become these employment spaces. These are not labor workshops. They need to be autonomous opportunities. And that is why social and solidary economy is important. It has to be a genuine labor development opportunity. There is intersectoral work also, and interdisciplinary, and universities could become a good link between civil society, government policies, and it could be very interesting to consider. There could even be a public-private partnership in order to generate one of these models for social inclusion. I've run out of time, but you can find more information on these sites, and we thank you very much for this opportunity. Let me now hand over to my colleagues.
Thank you so much. We're here from Argentina. If you can share the video, because we would like to show you a picture and tell you a little bit about the experience that we have in Chubut, Argentina. So we're going to tell you a little bit. So the images that we're going to be showing you is what we're doing. The Caldero is a social enterprise. It's in a tool that we have in this region. We decided that this is what's good for Argentina. In June, it will be 1 year that we've had. So we are part of the network of social enterprises, and it's another tool that we have, and something that has been working for 15 years, and we are part of the social network of the countries. We have people having mental health problems and also living in violent conditions, and it's open space for the communities. People arrive and they're provided with services, healthcare services at the municipality level. And because they couldn't receive those in their town, so they come here. As you can see in the picture, they do ceramics and they do handicrafts. So it's all the services that we provide here. And the people that come here, they enjoy a productive life, and they already start working in all the productive process. Currently, we sell more than 14 in 14 different locations throughout Argentina, even at the airport, and it's an enterprise that is also located in Buenos Aires. That's all the products that are made by those people. We have assemblies and meetings where we meet with the different entrepreneurs, and we have distribute with the different people that are involved, and we distribute machinery. Like last year, there was a trip to one of the municipalities that's about 3 hours away. This is all the important things that we had do. We can do the handicrafts, as we can see here. These are all the different activities that generate links. and involve people in the labor market, and also develop their social and economic skills, and also, depending on the interest, also develops autonomy, or allows them to ask for help when necessary. And also we have the teams that provide them the support. So these are people that are part of this program. This is what takes place day to day, every day. We're providing support to those people individually, but we also have collective objectives, but they're also targeted to each individual. So we're providing the support to develop the social relations. We have many histories, and we have many success stories of people that have been able to achieve independent living. They have their own homes, and they probably have gone to the gym for the first time, something they haven't done for a long time. So after 10 years, they have been able to do a lot of things. Finally, they have been able to find a job. So the simple things as even go out to eat in a restaurant. So this is a whole universe of support and follow-up that is given to them on a day-to-day basis. And this is what happens in El Caldero day to day. It's not only we have a focus on the productive area, but we also have some other support of other types. We have all the other techniques that we use to provide the support. So as other people said, that there is a lot of challenges challenges that we're facing given the economic conditions. So in this context, we're going to be working the skills for work, and also we have provided internships through the municipality, and also providing this to people that were interested, and also working in ceramics and people that showed also interest in those activities. And there is a group of women that became interested also in ceramics. So we got them involved in an enterprise, and they're working, and they're already developing these products. And also, so we are providing that support, and we're strengthening that. And we also have an artisan workshop for them. So we have a seeder, because we don't have any training or the ability for that, or halfway houses, but we have two tools, which is the orchard and the caldero, or the workshop where they're working. So what we can see through all of this, that this has to be open and available to all of the people as a seed for experiences. So it's just a little bit of everything that we work in many disciplines. And this is the contact information. And so this is what we do in order not only to find inputs, but to provide training. So whatever we can get a hand of to help us, we're very interested in having firsthand the experience of what's going on. So we like to know the individual experiences of each person, which also we need to also, of course, we need to know the theory part and also the practice, but also to know what goes on in the day-to-day. Good afternoon. My name is Raúl Tito Quintuprao. We also face all the same issues as all the other ones, the presenters. We're also working in the mental health area. We also face problems where that we can see that have been caused by the death of loved ones. So we also deal with that. This is something that led me to spend a lot of time in a very vulnerable situation, because I went through that. So I was trying to find some other support in order to channel my problem and to deal with what was going on, what was happening after about a year. Finally, I was searching for other alternatives. And after some time, I was finally able to access mental health area and the services. So finally, I was able to receive a treatment, and then I was reserved to specialists, and that's where I found a space where I was able to develop myself through the knowledge of arts and crafts and other activities, and also at the same time receiving the psychiatric treatment that I was receiving at the same time, but at the same time, I was able to spend a little more time, which has helped me go through the most difficult time for somebody who is under a lot of medication. So that kind of helped my anxiety and all it helped relieve a lot of the conditions. So at the same time, not only it helped me with my physical condition, but also with my labor condition, because all of my life, ever since I was 14 years old, I had been working in other jobs which had nothing to do with this area. So it was something new for me. But anyhow, at that time, I had to go through those problems and difficulties, and I was not prepared for that. So, but those all helped me. But then, after about a year of treatment, then I was going to be discharged from treatment, and then here with Marina, together with the mental health care team and with the psychiatrist who was giving me the treatment. So together they proposed to me from being a patient to joining one of the teams at the shops, at the arts and crafts team. So that started a different path for me. But at the same time, that was a new stage that I was able to overcome my problems. And that worked out very well. And well, even before the pandemic, I started teaching ceramic and crafts workshop and more recreational activities in the afternoons. So all throughout the pandemic, that was in the afternoon that I was teaching those workshops. And at the same time, I was part of the team with Christian and Medina and with new members, Paula. So that would be more or less that stage that I had to go through when I went through that ceramic shop. Something that we always say, that we always need to go out to find volunteers to help us, because this is a place where we can create those links and relations with people, and there are many people that participate here. They know that this is a place where they can go to ask for help. So this is something that is very helpful. And this is in addition to the external support that they can receive. So this is something that we are doing right now. Thank you so much. Well, thank you so much to both of you for being here and for sharing your experiences. I believe that the presentation was able to give us a holistic view of how you're working from the public policy point of view, the coordination through the El Caldero program, and also Tito's experience when he was telling us about his own personal experience throughout the process. So we appreciate this very much. We thank you and congratulate you. Not only congratulate you for the great work that you're doing, but for something beautiful that you're doing, because those arts and crafts are beautiful. In fact, in the chat, many of the participants are also congratulating you for the work that you're doing in all of those areas. So once again, congratulations. Well, we have a few minutes for questions. There are several questions. Also, I would like to say that there are many questions, and we'll try to deal with the most that we can here, so we can capture those that can either summarize or approach more specific areas that we have been discussing. So one very simple question is what challenges or difficulties have you encountered in your work in the Caldero? What difficulties do you find along the way? Well, it has to do with the physical space was the one of the challenges that we have, and the space, because we have we have also working in the area of education and the area of health. So it's hard for us to be working in different areas. There is an agreement with different institutions that provide that kind of support. So we've been improving along the way and working together, of course, with the families and all the support that we can get. But there isn't a political decision in order to define what are the right areas for us to be working on, because we would need some areas that have to do with the productive activity. Last year, we presented a project, and I'm sure Patricia is around here hearing about that, a project which is still pending, but is one of the very important issues that we're working on physical activity. Also in the rural areas, what we find is that many times the inputs that we have that we need, because either they're purchased through different ways, but then we need a practice so we cannot compete with all the other medical technology, but it has to do with financing and also with political decisions in what area, as to what area we're going to be working on. Simply to say that at this time we are operating based on in a very old location, but we have the challenge that we try to create more family relations with the users, so people that come through the program and the project, to link them together, and also at the same time to find a way to keep it going, because this is something that there is a very difficult economic situation in the country, so it will be a shame. This will stop operating, because there are many people at this time that they are going through a very difficult situation. So finding that possibility and that space beyond the difficulties, and the human technical team that we have helping us is very important, and it's a great asset for us to help those people who are going through difficult times. So this is a place where they can overcome the problems and they can make progress and go ahead with their lives. Also about the understanding of the different institutional actors. That's why for us it's important to have cooperation with the different institutions, and that's why there should be law for that. But sometimes implementing that, putting that into practice, and for them to understand, it's very difficult. So it's a need, of course, to have that coordination, and that's a challenge for us.
Thank you very much. That was very clear. I'm not seeing many questions, but many people are actually congratulating you in the chat. We're also seeing comments about similar experiences being carried out in other countries. I have two questions that perhaps repetitive. But first of all, where did you obtain the material and economic resources in order to conduct these workshops? And then there's a question. No, that's it. That's the only question for the time being. Well, we have Marcela here, and she can tell you how we started up. But first, it was with coordination with a workshop counting on the municipality. So we had agreements with health and municipality. Then there was a civil society. They participated in financing that allowed us to procure some equipment. Then there was material that the municipality had been using for many years. So we took them over and were able to start them up again, such as some furnaces that weren't really being used fully. And then a lot of work going to different licitations, going to different activities in order to obtain funding. So one had to just be very alert And we made a presentation to the mental health unit at the ministry to obtain additional equipment. So we're always alert and looking out for where we can find partnerships and obtain material, because sometimes we need health personnel and staffing. Everything is we build on. Sometimes we're able to sell some of the products and this provides us some income, but we're looking out for collaboration at all times and financing wherever we can. Sometimes we need financing for training, for developing skills. So we just look out different ways to manage. Let me add something to that. In our case, just as Marina and Tito just said, but we also began and currently do have funding from the regional government as well as from the National Secretariat for Disability. And that was financing to train municipalities, for instance, at the national level. But what is very important, and part of what we do in supporting the different cooperatives, is seeking out financing, and they themselves need to learn how to do it. So we provide them support in developing those skills as well, because we want them to become sustainable. We want them to know how to compete and how to obtain this funding to ensure their sustainability. But sustainability has to be sought also independently from state support or financing. So they need to know how to sell their services, their products. This takes time to build up, obviously, and it is one of the critical aspects because it's, after all, sustainability. But we want them to be independently sustainable, and that is something that we are reinforcing at all times. There are some employment projects nationally. We have also presented our case there. There are scholarships for people while they are being trained. And we're also improving the quality of products, as Soledad said, where the products are better quality, it's easier to sell them. And that, again, reinforces the opportunities and chances for sustainability. We are moving towards the end of our seminar or webinar. I'd like to give the floor to Marcela. I don't know if you have some final comments you'd like to share with everyone. Well, thank you very much. In principle, I have supported the startup of El Caldero as well as the startup of another collaboration between South-South universities. And I was able to see these processes close up. I saw how they started up, the history, how empowering they are. And taking Franco's words, in Latin America, the development of community health care and the intersection of these different conceptual fields can give us some crucial notions, allowing us to understand the practices, public policies, and different ideas from models that don't always flow in the manner that we really need it in our context, where we have a lot of inequality and poverty, which are actually increasing. Poverty itself is a very complex issue that makes us think about mental health. And this is not so much in the realm of psychiatry. The intersectoral aspect is very important, as we've been able to understand today. And universities can put ourselves at the service of the community process that have on the horizon improving the quality of life of the population and help to develop systems and to have different benchmarks and programs that can be scaled up, beginning with something very small. But universities do have the tools to create networks, to support them, to help in exchanging ideas, but also making available our tools so that we don't have to be starting from zero each time, starting from scratch, but to take advantage of existing experiences from Latin America. Thank you very much, Marcela. Your comments are very interesting. I'd like to close with one last question, and I think that in some manner it does round out the ideas that we have been discussing during this webinar. And the question is, do you not believe that health professionals ought to work in closer contact with the community, identifying community resources and working more frequently in a model focusing on health instead of pathogens, taking advantage of the resources available to the people in the places where they live? I don't know who would like to attempt an answer to this question. Is that question for all of us? Well, it was, well, perhaps each of you could just share a short sentence to answer the question. So let's do a quick round. Well, since I was the first, I do believe that indeed, yes, when we were thinking of what could be done about PSE, there are many things that can be done in this area to solve social inequality problems. But these are actually originate outside of the health system. It is not the health system that's going to be able to find a solution alone. They need to partner with others, and the social sector is very important. But many things can be done from the health services and primary care. And your question is key, mapping assets, that what is allowed socially in the clinical ambit. People don't necessarily have to go to another health specialist. They need to be put in touch with the resources and assets that are available in their community, such as the example we just saw. And for that, what is needed is information generated by the health system and by clinical practice. So there are key openings in order to achieve this. Thank you so much, Fabricio. Franco, let me offer the floor to you if you'd like to chime in. Yes, I think I did answer something along this line earlier today. Yes, obviously, the answer is yes, the community model for mental health. This is nothing new. We have been discussing this model for years now, for decades, even prior to the Caracas Declaration in the 60s and 70s. There was already interesting work being carried out in the region having to do with community work. Chile, Brazil, Argentina also, but I'm thinking about Peru, working with indigenous communities and people in disadvantaged socioeconomic conditions. In Latin America, there's a long tradition for this, as Marcio pointed out. However, what appears to be complex is these backtracking or sliding back. I have no other term to describe it. We sometimes see it. We seem to be on the right path, but then there is a new focus on pathogens and symptoms. Every now and then it rears its head. There have been historical discussions about this, and as I said earlier, with regard to a vision of mental health from public health would actually make a valuable contribution. I think that the community mental health models in the region are strong. They have had good outcomes, but they need to be political matched with other models that actually are not on the same path. So there are isolated cases, they appear like islands in a market that is difficult to navigate, and people are not rowing in the same direction in these turbulent seas. Well, thank you very much, Franco, for these words. So I don't know if Soledad, Tito, Marina, or Marcela, which of you would like to answer? Marcela. Yeah, just hearing to Franco, there's something important that I'd like to bring up. We have many devices and proposals in the formal environment of caregiving, but we sometimes need to look at the public policies. I think it's necessary for these formal networks to coordinated with informal networks in the community, because they're very, very powerful and they provide support when we have the public policy process. This is very particular in Latin America. We saw it during the pandemic. Learning, I believe, ought to be that not only resort to these networks when there are public policies in jeopardy, but we also need to the informal caregiving system. This is a lesson that ought to be drawn from Latin America and need to be enhanced, because it is fundamental for work in health and public health, as well as in public mental health. Very well. Once again, I'd like to thank you all for your answers and for sharing your experience and knowledge with everyone. It is the end of this webinar. So I'd like to offer the floor to Carmen for her closing remarks to end this webinar. Carmen, please go ahead. I'd like to thank each and every one of you. Quite honestly, I have thoroughly enjoyed this webinar and everything you shared with us. I'd like to perhaps convey some messages that reflect some of the elements. It's impossible to reflect absolutely everything, but let us recall that people living with mental disorders can also attain good levels of well-being. For this, it is essential to tackle the social conditions of these people, that they have decent housing with quality employment, receive support and the right kind of treatment, ensure social inclusion and support, such as what we have seen in the examples presented to us today. And that way to free them of that discrimination and stigma that unfortunately is so present in mental health. And all of this, this level of intersectoral activity that has been strongly emphasized today, and considering also the life course, I do believe that the excellent speakers today have shared with us important examples, especially from Chile and Argentina, but also we have heard about other examples, allowing us to really be able to have an impact on mental health going through the social determinants approach. I'd like to repeat Marina's word that these are a seedbed or a nursery. So I hope that sharing these experiences and this knowledge, as we did today, follow this same direction. We need to be the seed for hope, but hope that is reality-based despite the barriers and the problems that we face. So thank you all and congratulations. As we have seen in the chat, there is a tremendous interest, and we have seen how people are truly involved. We have had over 500 participants throughout this webinar. So let me congratulate you for all the work that you're doing, and thank you so much for sharing. Fabrizio, Franco, Maria Soledad, Marina, Tito. Thank you, Kathy, also for facilitating and moderating our session today. So I thank each and every one of the participants for your involvement, and we hope to see you again soon at future webinars. So thank you all. Bye-bye. Thank you. And in closing, a technical aspect, you'll be able to find the recording and today's presentations on the webpage of today's event, and I have shown it in the chat, so you have the link available to you there in the chat. So once again, thank you all for your participation, and hope you enjoy the rest of the day and look forward to seeing you again next time and to working together. Thank you and see you soon.